diarrhea. Let's welcome Dr. Patel.
All right, thank you. Okay, thank you so much. So, yeah, I was just told that you guys finished your ID month, and so it's nice that we're going to start off with an internist approach to diarrhea. It's going to be a two-part talk since I'm going to be coming back a little later this month. So the first part we're going to be focusing on is acute diarrhea, and of course, acute diarrhea is largely infectious, so it'll be a nice little segue into GI month. So let's start off with a question. Anybody want to go ahead and read? So what do you guys think? You think a colonoscopy would be considered in this patient at this point? No. Supportive care? What about a stool culture or antibiotics? You have a 25-year-old, she's had 3 days of diarrhea already. She appears mildly ill. You see that? What do you think? Mm-hmm. Good, good. So you're thinking no antibiotics are indicated at this point. What about stool cultures? What's the point? Someone said, what's the point? Right. Okay, good. So what are you thinking? If you say, what's the point? You think it's just mild form of either viral, bacterial, or some other cause of diarrhea. Acute diarrhea, you're saying, right? So yeah, so you guys are choosing D, so supportive care. So this is kind of the point we're going to be driving home with acute diarrhea is what tests to order, what tests are available to order, whether we should or should not order them, and of course what our differential should be with when focusing on acute diarrhea, how to approach it clinically at least. Okay, so just to kind of recap, most acute diarrhea in the developing countries is self-limiting or viral infections. Otherwise, healthy women with no alarming features, and the alarming features you're typically looking for GI bleeding, any significant dehydration or systemic effects from the diarrhea itself, even though it's been 3 days, fevers, abdominal tenderness, or someone mentioned it earlier as well, recent antibiotic use. Supportive care is, what we mean by that is some oral fluid intake, some pain medication like acetaminophen perhaps, and we'll talk a little bit more about these things during our talk. Okay, so just a kind of objective and approach to the talk so we can focus on what our point is. So we're going to talk a little bit about the epidemiology, the definition of diarrhea, and then the broad categories, how we can divide it up into the broad categories so we can approach a case of diarrhea clinically. Specifics within each category, a little bit smaller details, a clinical approach to the diagnosis and then management, and then a little bit about high-value care and then board relevance as well, cost and testing, high-yield facts, and then some questions at the end as well, okay? So a little epidemiology. When we think of diarrhea, especially in the developed world, we think of something that's not too serious. I mean, I think every single person in this room at one point or another has experienced a diarrheal illness. But if you put it all together in the world, it actually puts together a large burden in healthcare. 2 million deaths worldwide do occur per year from diarrhea itself, largely in undeveloped societies. But if you look at this in the U.S., it's recorded that 200 million episodes of diarrhea occur per year throughout the population within the U.S. Roughly 900,000 individuals seek medical consultation or are hospitalized, primarily the elderly. And then 5,000 individuals die from their diarrheal illness, which is still quite a bit for something that we usually should have a good grip on. And then, of course, we have a $150 million cost burden annually, which also include missed work days, which is a large cost burden to the United States. And then, of course, you can imagine that these statistics may even be worse in less developed countries. This was a really interesting table that I saw in Harrison. It's the Global Daily. It's called Disability Adjusted Life Years. It's an attempt in 1990 that was made by the World Health Organization to compute what the burden on society is for each disease. And if you look over here, diarrheal diseases from 1990 to 2010 didn't really move down in the list much. So it's important to note that, something we as physicians need to really pay attention to, learn how to identify potential sources of why individuals may have diarrhea, both inpatient and also in the primary care setting, and then also treat and manage them appropriately. So let's jump into the definition. So diarrhea is a symptom, right? It's a symptom of something greater. Loosely defined as an increase in stool frequency, usually 3 or more days. Liquidity, you see this Bristol stool chart that shows us a little way of defining how loose or hard the stool is. So type 5, 6, and 7 is typically what we think of when we think of diarrhea. Or then volume. It's an attempt to have an objective way of defining diarrhea, which they say is more than 200 grams per day. But again, this is not usually used clinically because a lot of different things can vary. Different things can vary the weights of the stool. For example, someone with a high fiber intake can have up to 300 grams a day of stool, which would be normal for them. Healthcare providers. So it's also important to clarify what a patient might mean by diarrhea. Not everybody is consistent when they say, "Oh, I'm experiencing diarrhea." So healthcare providers typically think of diarrhea when they say increase in stool frequency relative to the stool consistency. Typically 3 or more loose bowel movements per day. That's different from hyperdefecation, which is normal-ish bowel movements but happening more times a day, typically seen in something like IBS. And then oftentimes our patients will come in, the general public, and they will specifically relate diarrhea to the characteristic of the diarrhea or past stool. Even if it's once a day, they'll say, "Oh, loose stool." They're having a diarrhea. Also, they might confuse diarrhea with urgency or fecal incontinency. So these are things that you want to also ask detailed questions for in your history to elucidate what they actually mean by diarrhea itself. And then just another definition right here. Dysentery is diarrhea with abdominal pain, cramping, mucus, and blood in the stool. Typically what dysentery is. So let's talk a little bit about general physiology. The physiology of the gut goes way into detail, but we're going to just touch the surface. So the small intestines and colon usually absorb 99% of the oral intake of water or liquids. Usually that includes the saliva as well, and that can be up to 9 to 10 liters per day. You can see that in this diagram. There's 10 liters going in from the stomach, the duodenum, into the small intestines, where they're absorbed, and then usually 1% of that is being excreted within the feces. Water is transported by osmotic forces. It's not actively transported in. The solutes, the electrolytes are, and then water follows along. And then, of course, normally absorption is more than secretion within the GI tract. And, of course, decrease in absorption or an increase in secretion typically equates to diarrhea. So diarrhea is simply a large amount of water or liquid content within the small intestines and colon that's either not able to be absorbed properly, whether through deficiencies in the mechanism of active transport or deficiencies in the oncotic forces, and then, of course, hypersecretion in certain pathophysiological processes, like, for example, cholera. So general pathophysiological process of diarrhea. So this can go into very much details, but just to kind of dilute it down to just basics, each process is different depending on the process of the diarrhea itself, whether if it's infectious, non-infectious, an anatomical process. And again, it's a symptom, right? Diarrhea is a symptom of the overall process that's going on. So disruption in the epithelial electrolyte transport or its regulatory system by toxins, drugs, hormones, and cytokines is a major cause of diarrhea. There's something called the ALPINES, Alpines network, or the neurohormonal pathway. It consists of multiple different markers and transporters and hormones, autocrine, luminal, pancreatic, paracrine, immune, neuronal, and then endocrine. All of these things determine absorption and secretion rates and, of course, muscle motility as well. So you can see how they affect the paracellular pathways, the epithelium within the GI tract, the muscles, the motility, and then the blood flow and metabolism of the GI tract. And all of these things can be altered that can cause variety of different forms of diarrhea. A little bit more complicated would be chronic diarrhea, which we'll get into the next lecture, but acute diarrhea typically focuses on very superficial pathways. And then incomplete or insufficient absorption of water from the intestinal lumen content relative to the amount passing through, or being secreted is what causes diarrhea. Okay? Excess stool water then causes decrease in stool consistency. So again, the big picture. So how do you classify these symptoms or these presentations clinically? There's a lot of different books and articles that say, oh, you can classify diarrhea in different ways, either large volume versus small volume, osmotic versus secretory, watery versus fat versus inflammatory. But again, as a clinician, you want the best approach is the one that's going to be able to help you with identifying, using diagnostic tools that you do have, identifying the reason, and then with that, having some kind of management from that, right? So the best way that most people end up approaching this is initially with, is it acute, is it persistent, or is it chronic diarrhea? And then, of course, chronic diarrhea can also be broken on later on. We'll talk about which is osmotic versus secretory versus other forms of diarrhea as well. So one important note to make is also things that can mimic diarrhea is also something to consider. For example, pseudodiarrhea, fecal incontinence, or fecal impaction. Severe constipation can also be presented by the patient as diarrhea because you have severe impaction, fecal impaction that causes irritation of the mucosal lining, and you have this secretion around the impacted stool, which leaks out as diarrhea. So the patient often presents as, oh, I have liquidy stool or diarrhea, but really they actually have fecal impaction. So it's important to remember. So approach to acute diarrhea, because that's what we're going to talk about first, right? Acute diarrhea, less than 2 weeks, typically 14 days. So it counts for most cases of diarrhea that we see in the U.S., and 90% of the acute diarrheas that we do see are related to some sort of infection. They're infectious diarrheas. And then 10% are typically non-infectious, which is related to medications, toxin ingestions, ischemia, or some sorts of cancer as well. Okay, so another approach. So what's the first thing that you guys think is very important when you have a patient that comes in and says, Doc, I have diarrhea for about 3 to 4, maybe 5 days? What is your first thought? But what is your first step? Like, what is your first step to approach this patient? What are you going to do first? Yeah, get a history, right? You're going to have to get a very, very detailed history. So, no problem. Oh, yeah, no problem. Yeah, I can wait. No problem. Think about what you'll ask in history, right? That's right. Exactly, right? History and physical is always the initial answer. What's the best next step? We have history, physical exam. How many of you have seen a patient with either acute or chronic diarrhea in the clinics so far? That's it? No, yeah, that's it? What about inpatient? Everybody has diarrhea, right? Diarrhea or constipation. Hello? I think there's still
Yeah.
Hey. Hello.
Yes, we can.
Hi. Can you hear us?
Yeah.
Who is this? Paul?
Paul.
Hey, Paul.
Yeah. Hey, how are you? Yeah. Go ahead.
Do you have the link? WebEx link?
Let me refresh. Not yet. But you should go ahead. But I think.
Oh, you're too kind. Okay. So, yeah, just look for the link. Dr. Grossman's sending it to you, okay? And jump in whenever you can. So we'll continue. So the approach is first and foremost with a detailed history of the patient. History will help you elucidate the cause of the diarrhea in most cases, especially since most cases are infectious. What kind of questions on history do you want to ask? Give me examples. Sure. How long? Right. So that's a good question. How long have you been having diarrhea? That's always important. What else? Travel. Someone said travel history. Right. Okay, I haven't traveled anywhere. What else? Good. Yeah. So we got a bunch of them, all like a bolus of answers all at once. So yeah. So someone said consistency. Whether it smells, whether it doesn't smell, color, blood, no blood. Someone else said, what was that? Pain. Is it painful? Correct. So there's a bunch of questions you want to ask. I mean, you want to go down and really spend some time in a detailed history, starting from what medications the patient takes to what food they've eaten. Anybody else in the family that's sick? Just recently there was an outbreak of something in Westchester. I can't remember what it was. But where do they eat? What restaurants? Anybody else gets sick? So all of these things are important to consider whenever you're taking history, and also considering what this Department of Health might be saying. Recently, I think there was maybe 3 months ago, there was Minnesota sent us an email saying that there was a outbreak of cyclospora, especially in HIV patients. Right, so all of these things are important to consider whenever taking the history, of course. So start off with the history and physical. So what do you want to do after the history and physical? So a lot of these, of course, there's a lot of different ways of approaching it, but it seems like a lot of the clinical articles that are published like to approach it this way, acute diarrhea. It's with the history and physical trying to determine, is it inflammatory diarrhea or non-inflammatory diarrhea? Because that makes a difference in whether you will order tests and treat the patient as well, okay? So let's move on right over here. So let's talk about infectious diarrhea, inflammatory diarrhea and non-inflammatory diarrhea. So let's talk a little bit about what it is, pathophysiology, history, findings, and then possible etiology. So in non-inflammatory diarrhea are typically your more self-limiting diarrheas, and usually the etiology of these diarrheas are viral. It can occasionally be bacterial, mild bacterial or parasitic infections. And then we have, conversely, inflammatory diarrheas, which are usually your more invasive bacterial infections or toxin-producing bacteria that cause this inflammatory diarrhea. Most likely to promote intestinal secretion without significant disruption is non-inflammatory, and then inflammatory is more likely to disrupt mucosal integrity, which is very important, and which may lead to tissue invasion and destruction. Very commonly, that can also lead to leukocytosis within the stool, blood in the stool, and then you see history of physical exam findings, fevers, abdominal pain, tenesmus. Someone said pain in the history. And then in non-infectious, you typically have more along the lines of non-bloody, watery stools, large volume, nausea, vomiting may also be present. Again, big laboratory findings, absent leukocytes in the non-inflammatory and then present white blood cells within the inflammatory cell, diarrhea. And then we'll talk a little bit more about the pathogens when we go further, okay? So we talked about acute diarrhea. History and physical is important, differentiating non-inflammatory versus inflammatory. And then, of course, we said non-inflammatory is typically self-limiting, with minimal workup needed. And then inflammatory diarrhea typically requires some sort of workup and may also require treatment as well. And then, so diagnostic testing is what we're going to talk about next. This is just kind of summarizing the same thing I had mentioned. So before we go into the testing that we do have available that we commonly use for patients who come in with acute diarrhea, let's talk a little bit about the etiology. We talked about history and physical key findings, so let's talk about some historical findings and see if we can identify the organism just based off that. So let's talk about a patient that came in afebrile, pain, abdominal pain with bloody diarrhea. What do you guys think? Patient comes into you, patient's afebrile, but is complaining of abdominal pain, significant abdominal pain, and has bloody diarrhea. What is your thought? Inflammatory bowel disease. Okay. Patient came in with 2 days to 3 days of diarrhea. So inflammatory diarrhea disease might be a little bit more chronic, right? Yeah. What was that? Yes, it is. So what bacteria do you think this is? It's classic. Afebrile, but with bloody diarrhea. Afebrile. No fever, but with bloody diarrhea. Someone said it. I heard it. No. Shigella toxin. There you go. Shiga toxin producing E. coli, right? Shiga toxin producing E. coli. Very good. So we all know bloody stools typically present with also Salmonella, Shigella, Campylobacter, often with fevers, right? What about cramping, consumption of untreated water? Giardia, right? Maybe oftentimes in a stream, patient went camping. What about this classic step one, fried rice? Right. What about raw or ground beef? Patient went to Five Guys Burgers or something like that. Or what was the one in California? No, not Bojangles. Huh? In-N-Out Burger, that's what it was, I think. Yeah, so Shiga toxin producing E. coli, or O15787, right? Enter hemorrhagic E. coli. What about seafood? Patient went into like the Long Island over here and had some Oysters, yeah. So that's for standard Vibrio. So see how, history is essential to identifying, causes of acute diarrhea. Oftentimes, we don't take enough history with our patients. We really don't. What about hospital admission? Patients are hospitalized. You go upstairs and, you sure? Are you sure? All right. Also, treatment adverse effects. That's an important thing, right? Patients in ICU. What about patients in ICU? All of a sudden, critical condition, has diarrhea. You do C. diff. C. diff's negative. What are your thoughts? CMV? So you say, yeah, CMV. Okay, if the patient's immunocompromised, it's very possible. Patients on pressors, vasopressors. Ischemic, yeah, that's another thought as well, right? So what else do we have here? Medications, right? There's another list of bunch of medications. I didn't really blank that one out. Pregnancy. What about a patient that comes in? Pregnancy, now with diarrhea, acute. What are your thoughts? What are your concerns at least? Listeria, right? What else? Has cold cuts. Patient A comes in cold cuts at a deli, came in with diarrhea. Listeria, right? Recent antibiotic use. What do you guys think this is? Are you sure? Yeah, okay. C. diff. And then, of course, what about traveled to a developing country, went to, I don't know, India, came back, went to see the Taj Mahal, came back, and then had diarrhea, huh? What? Hepatitis A, okay. Hepatitis A, maybe. Fecal oral, possibly mild side diarrhea, huh? Vibrio cholera, you think? Or cholera itself? Maybe. I mean, but you would, what's the most common? What's the most common form of diarrhea? What is the recourse? Traveler's diarrhea. So what is traveler's diarrhea? Right. Enterotoxigenic E. coli, right? Enterotoxigenic. That's the most common cause, right? Speaking of hepatitis A, yeah, there was a taco shop in Westchester that infected, I think, possibly close to 1,000 people with hepatitis A, I think, over the last 2 weeks. Yeah. So that, if you're in your clinics and someone comes in, diarrhea, maybe like a little bit of acute jaundice, check the LFTs, then, and they went to Westchester, think about that, acute hepatitis A infection. So very good. So I thought that this was a really interesting chart that was in one of the publications that I looked at when I was reviewing this. It's from some time back, but what they did was someone did a study with comparing typical organisms that they've identified with the symptoms or physical exam findings and history findings that you have and the percentages. So again, that just kind of goes to show that physical exam and history is extremely important in trying to identify the etiology of what might be causing this acute diarrhea, okay? So let's jump into what initial diagnostic testing that's available. So of course you want to start off with your basic labs. When you are considering ordering a test, right? Like if you have an inflammatory diarrhea and patients having diarrhea for a number of days, fevers, abdominal pain, maybe blood in the stool. So we can start off with certain tests. So, one of the tests we have available is occult blood. Just remember that it's rapid, it's cheap, typically. It's a good way of telling if there is any blood in the stool or not. If you have any concerns, maybe the patient had some fevers, had a little bit more abdominal pain, you want to test if this is inflammatory diarrhea with some bloody stools or not. That can determine whether we want to give antibiotics or not. So usually has 71% sensitivity, 80% specificity when combined. And then in the developed world, actually, it's less. I tried, the articles I read mentioned it was less. I'm still trying to find out why exactly it is less. But I couldn't elucidate exactly why, but I'll get back to you why that is. I didn't have a chance to look into why it is, but 2 or 3 articles mentioned that it's less sensitive and specific here in the developed world. I'm not sure why. It could have something to do with our rate of gastritis, gastropathies, also that, and medications that we take. Fecal occult blood is not very specific to just globulin itself. It could be also that as well. So I think our diet, iron supplementation, all this stuff, unlike the FIT, for example, immunochemical, histochemical testing that specifically tests for globulin, occult blood does not, right? So still leukocytes. So it depends on several factors. So this is a good test to tell if there's any white blood cells within the stool, but the leukocytes itself depends on several factors. It depends on handling, storage, and technique. So all of these things can make the sensitivity and specificity very variable with the test itself. There is another test that's more favored by a lot of institutions called lactoferrin, but I don't think we have that here because it's a little bit more expensive of a test, but it's a 90% more specific than is the white blood cells or leukocyte test. Okay, there we go, the lactoferrin test. Stool culture. So this is the big question. Everywhere we go, I feel like we see outside in the primary care facility, primary care setting, or even inpatient, we see when we're sending stool workup, they go ahead and just bunch in the culture as well, because guess what? It's easier. If you're sending the stool, why not send it for culture, right? Should we do that as a good practice? No, not really. It's a big if. So it's very expensive. If you look at the data that we have, it's the most expensive test we have when you're doing a stool workup. $950 to $1,200 per culture that's sent that's actually positive. Because you got to think about this. Someone actually has a tech, has to take this, has to process the stool, has to put it on the petri dishes, has to incubate it, and it has to be in a center that, a laboratory setting that's actually certified to do this as well because of contamination. So all of that stuff takes a lot of resources up. And of course, if obtained, only positive, what did I write over here? So it's not even that high of a yield as well when we do obtain it. So if we do have these, let's say, positive blood or positive white blood cells, only 30% are still diagnostic. So stool cultures are really something that's reserved for something where we have a little bit longer diarrhea, or we're definitely suspecting something specific, maybe salmonella, to actually identify the cause. Then we would typically recommend stool cultures itself. So what did I put over here? So what is this? What test am I going to come up? What is this? Does anybody know what organism this is, by the way? Yeah, it's entamoeba. Very good. Yeah, entamoeba, with the circular parasite with these 3 tiny cysts within the center. So ONP is something that we routinely order, but again, routine testing is not cost effective. Again, based off the history that you do obtain of the diarrhea, and if you're suspecting maybe that there is some kind of parasitic cause, or if the diarrhea has now been into the persistent or even chronic phase, then you can consider doing stool ONP. Right there, you see, indicated more than 7 days is then typically indicated to see if there is any parasitic causes. Other history findings that you typically have are infants or families with infants in daycare, camping, mountaineering, or of course immunocompromised individuals. And then we have our C. diff test as well. So if suspected nosocomial infections or post-antibiotic diarrhea, then we have our C. diff toxins and then C. diff PCR. In the hospital, we have C. diff PCR. If a C. diff PCR is negative, patient's having diarrhea, do you need to order the C. diff PCR one more time again? No, typically, yeah, right? No, not like how we used to have when we had the toxins A and B, where we ordered it maybe 1, 2, or 3 times. PCR is like above 95% specific and sensitive, and so you don't typically need to order it again. You can believe the test results. Correct, yeah, it is. It's on the boards. It is. And then endoscopy. So is that something we'll typically consider for a acute diarrhea? No, not really. I mean, my short time here in the endoscopy unit, I think I've done a decent amount of, I think, over 60, 70, 80 colonoscopies now. It's high volume. It's amazing. But, a lot of these have been diagnostic for diarrhea. And typically we don't do them. We'll never do them in obviously acute diarrhea. We'll give them a chance. And even in chronic diarrhea, a lot of the, we don't see typical causes. Occasionally we'll talk about causes when I have the chronic diarrhea lecture, where we have diagnosed people with some really interesting things like collagenous, microscopic, what do you call it? Yeah, exactly, right. Eosinophilic colitis, cholangitis colitis, all these things that can cause diarrhea chronically, but we'll talk about that later. This is just another chart I threw up in there. It just goes to show the differences in findings between the bacterial organism that we commonly see in acute infectious diarrhea and then their findings. Again, showing that how it's important to have history, physical exam findings. And then this is right here, Shiga toxin producing E. coli. That first question I had on that chart. It's atypical to have a fever, but you typically do have abdominal pain and bloody stool. And then, of course, the consideration of whether to treat the patient like this or not has to really be made, because if you do give them antibiotics, it's been shown that you could even worsen the clinical course, right? So these are why it's important to identify these clinical findings. So let's go into what we have for therapy and management of people with acute diarrhea. So you guys already answered that question initially. Most cases of acute diarrhea are self-limiting and will require just supportive care. So let's start off. What do we have in our battery of different tools to treat patients and manage patients with acute diarrhea? So let's start off. The first and foremost thing, which is cost-effective and the safest, is oral rehydration therapy. Oral rehydration is obviously preferred throughout the world because it's important, as long as they can tolerate PO. You can see right over here, if severe, you can occasionally need IV fluid. Also, depending on the electrolytes, depending on the clinical picture, are they dehydrated, orthostatic, unable to tolerate PO fluids, then you can consider a short course of observation or admission. and give them IV fluids. But the World Health Organization themselves have a specific WHO rehydration solution that they actually administer throughout the world. It's a specific. They have these big campaigns that go around the world that talk about these, so that people like understand in layman's terms what to do when their family comes down with maybe cholera or some sort of other diarrheal diseases in third world countries. So that's usually water, salt, and glucose. They actually have. You can make this at home, and they specifically do this so that people in third world countries can do this. It's a half a tablespoon of salt, 6 of sugar, and then within 1 liter of water. And this mixture has shown to actually decrease the emesis and stool output and the need for IV fluids and also hyponatremia. It's shown in clinical studies that to help. So that solution is very important to remember. And it's usually around, that solution is about 250 milliosmoles per liter. Previously, they had something a little bit higher, but now they've refined it. And of course, feeding is very important as well. Early feeding in diarrhea is important. People usually say, oh, if they're having diarrhea, just don't feed them. No, it's not true, because it's shown that if you do start early feeding, then the permeability within the intestinal lining is improved. And so that causes less of a secretion and less bacterial invasion as well of the mucosal walls. Brat diet that they have, which is usually, what is it, banana, rice, applesauce, and toast, right? Banana, rice, applesauce, and toast is not shown to actually help anything. So this is also an interesting chart that's published by the World Health Organization. This shows the World Health Organization's typical solution, oral hydration solution, compared to what we have on the market today. The closest that we have is Pedialyte and Rehydrolate. So these things, even when we have adults, especially elderly people who come in with acute diarrhea, we say, why don't you get a little bit of Pedialyte for the family member and have them take this at home to keep them hydrated, to keep them out of the hospital. You can also see it compared to what we see, people say, oh, why don't you drink a little bit of Gatorade or even chicken broth? And you see that they're really not equaled out to the solutions of what the World Health Organization recommends, actually, which can sometimes worsen diarrhea by osmotic forces or even cause more dehydration if there's too much sodium overall. So then our next step, what do we have for acute diarrhea as far as anti-diarrheal medication goes? So our most common one we have that's both used in hospitals and outside into the pharmacies is Imodium or loperamide, which is a mu receptor agonist. It decreases circular and longitudinal muscle peristalsis. And it also has some mild anti-circulatory effect. It's good in reducing diarrhea by 1 day and increasing the likelihood of a cure at 24 hours to 48 hours when given with antibiotics in traveler's diarrhea. Again, when you have a typical history and presentation of traveler's diarrhea, you can consider this with antibiotics, and it will often improve the symptoms and cure the patient a day or so sooner. But you remember, you have to be very cautious when giving these medications because it can also prolong the duration of illnesses in some forms of bloody infectious diarrheas. So you want to make sure, do they have C. diff? Do they have other form of enterohemorrhagic organisms that are at play? Then you don't want to prolong this exposure by giving them these kind of medications. For many, many years, we've had bismuth subsalicylate, Pepto-Bismol, which is a very common form of medication used when someone has diarrhea. And this is a combination pill. It has both anti-circulatory effects and has some mild antimicrobiological activity as well. And so it's some anti-inflammatory action as well. And so it's a good and safe alternative to give in both adults and children when they have when they're having diarrhea, even with fevers with inflammatory diarrhea. Back in the day, there was some chiropectate that had this medication, Etapligate, which is now not used in the U.S. anymore. Yeah, they've FDA banned it for various. I'm not sure why exactly, but they use them still in Canada and a few other places. But now chiropectate is actually the same as Pepto-Bismol. They use the same active ingredient. They do not use that previously absorbable medication anymore. Yeah. And then Lomotil, which is another medication that's often used, which has anti-motility and circulatory effects as well. Antibiotics. So that's the big question. So do we or do we not give antibiotics? So most acute diarrheal diseases are, again, self-limiting and do not typically need treatment with antibiotic therapy. Overuse of antibiotics can lead to resistance, alteration, or eradication of normal flora, which is now becoming more and more prominent. People are relating alterations of gut flora to things like obesity, even depression, inflammatory bowel disorders. And so it's really interesting with when we were talking about alterations of flora. Superinfections, and then induction of induction of toxins from toxin-producing bacteria. Breaking them apart with antibiotics may release more of the toxin, making more risks for example, HUS in certain conditions as well. However, when given appropriately, it is effective and decreases severity when treating. So there are certain antibiotics that we typically do give, ciprofloxacin, fluoroquinolones, that often do help a lot in certain infectious organisms like Campylobacter, and enteropathogenics, enteroinvasive E. coli, typically, if severe, we'll give antibiotics to. Salmonella, we don't usually, again, give antibiotics to because it can cause a carrier state in some cases. But if severe, we do consider, again, antibiotics for these. And then for certain parasitic infections, we'll consider antiparasitic medications like metronidazole. So it's all about knowing the organism that's infected, understanding how severe the infection is. If the infection is severe enough, then antibiotic therapy can be considered with caution. And then, of course, we have our typical infectious diarrhea from traveler's diarrhea. So a lot of times you will have a patient in the clinic come in, be like, hey, doc, I'm traveling to XYZ country where diarrhea is common. I've traveled there many times in the past, and I've typically gotten 1 or 2 bouts of diarrhea from eating outside, and so I just want to prevent this. What do I do? Can I have a prescription? And they seem like a pretty well-educated individual. They understand the risks and benefits. You can, consider here's a short course of possible antibiotics prophylactically if they need it, with some anti-motility agents. You can consider certain regimens like ciprofloxacin typically for traveler's diarrhea. Okay. Other things that we have in our tools for diarrheal diseases. So probiotics and zinc supplementations, actually. So probiotics, a lot of new studies coming out with probiotics, still kind of new in the market, but they're better studied in children than they are in adults. And they work by stimulating the immune system and competing for binding sites for intestinal epithelial cells, which prevent secretion, motility disorders within the intestines whenever you do have some kind of infection. And so it is something recommended. It doesn't hurt. People typically ask, well, is it good? Does it help any to take probiotics? Yeah, sure. You can try it. It might not be the sole thing that helps out, but it might help not eradicate the flora completely whenever you do take antibiotics, so they are recommended in certain patients. And then zinc supplementation has found better studies in children than they have in adults, especially in third world countries that have been found to decrease dehydration, duration of severity of diarrheal diseases by up to 20 to 40%. So it's also something to consider with patients as well, especially children patients that you may see. Other preventive measures that we typically have are very common sense and, of course, very important in preventing the further spread of diarrhea: hand washing, food safety, environmental safety, clean water, public health awareness. And then, of course, some vaccines are being tried in certain developed countries to prevent certain typical forms of infectious diarrheas, because they have a very large health burden because of these cases. They might not have access to health care that we typically have over here, even access to clean water, which can cause severe forms of dehydration and then mortality from that as well. Okay. So this is a nice little algorithm that's actually put out by the ACG, or American College of Gastroenterology. Kind of approach to acute diarrhea is itself, acute infectious diarrhea. So if you have passage of 3 or more unformed stools within 24 hours, plus some enteric symptoms such as nausea, vomiting, abdominal pain, cramping, tenesmus, fecal urgencies, and moderate to severe flatulence, you can consider oral therapy for all cases initially. Hydrate with fluids and salt intake. Foods such as soups, broth, saline, crackers can also help if the patient is not tolerating much PO. And then, of course, we review the World Health Organization solution. And then you can divide it up. Does it look watery diarrhea, non-infectious, non-inflammatory, or is it dysentery, which typically pushes you towards the inflammatory diarrheas? If it's a mild illness, you can just typically self-limiting. Oral hydration helps. Moderate to severe illness, you got to consider, do they need IV therapy? Do they need some more supportive care? Travelers associated diarrhea, you can consider the antibiotics we just previously discussed. Non-travelers associated diarrhea with fevers, kind of jumping to the infectious category again, or the inflammatory category. And then you can move on to this side where you want to differentiate. Is it happening by Shiga toxin producing E. coli infections, which you want to, again, do supportive care and cautiously use use antibiotics only if it's severe to prevent lysis of bacteria and then possible immune reactions. And then if it's, again, severe forms of traveler's diarrhea, it might require supportive therapy, inpatient, and then antibiotic therapy, IV as well. And then persistent diarrhea will move into what we're going to talk about next, persistent and chronic diarrhea, and the workup and diagnosis of that. So this is a kind of a snapshot from the board's basics for what they consider high yield for acute diarrhea. Okay, so again, right off the bat, majority of cases are self-limiting. So a lot of the questions you may see are going to be based off self-limiting illnesses. Okay, you can see right over here a couple of the organisms they might point out. 6 hours after ingestion of some foods are typically Staph aureus or Bacillus cereus, right? You guys mentioned with the fried rice. 8 to 14 hours after ingestion can be a Clostridium perfringens, and then more than 14 hours after ingestion is typically viral or enterotoxigenic bacteria. We also show that the medication history is also very important to take in the patient. They might show you some medication that they're taking that might elucidate more about what's causing the diarrhea. They do ask some questions more pertaining to Yersinia, E. coli, and Cryptosporidiasis in patients typically are immunocompromised. And then Giardia are common organisms that they will ask about that are parasitic as well. Therapy-wise, supportive and oral hydration and antidiarrheal medications are very important. And then you want to go back to don't be tricked. So do not order stool cultures for acute diarrhea less than 1 week. If there is more than 7 days, there might be a consideration or indication for considering, okay, stool ONP and cultures. Do not choose antibiotics for enterohemorrhagic E. coli. And do not choose loperamide or any anti-motility agents for acute diarrhea with fever or blood in the stool, right? Because you want to identify at this point, okay, well, what's causing the blood and is it appropriate to give anti-motility agents? So let's start off with another question. You want to start off with the next question, Ayla? Ken Paul still here? Are they still there? Yeah, you can go ahead. I mean, you can use that. It works, right? Hello, Paul. No? I think they got tired of my presentation. They got diarrhea. There you go.
But then we can hear you.
Oh, okay. There we go. There we go. See, they were listening.
All right. So a 52-year-old woman admitted 5 days ago with severe community-acquired pneumonia is evaluated for new onset of acute diarrhea. She's been treated with empiric antibiotic therapy consisting of ceftriaxone and azithromycin. She has had 5 liquid bowel movements in 24 hours. On physical examination, temperature is 100.2, blood pressure 122/64, pulse rate is 90 per minute, respiration 18 per minute. There are crackles in the right lung base. Abdominal examination reveals normal bowel sounds and no tenderness to palpation. Leukocyte count is 10,300. The results for C. diff toxin PCR on stool sample is negative. Which of the following is the most appropriate management? Order stool bacterial cultures, prescribe an anti-motility agent, prescribe metronidazole, repeat stool C. diff testing. So it's not D.
So it says not D. Why is that? Tell me why.
Because it was already sent and it was negative.
Right, so they sent the stool PCR, right? So the PCR is very highly sensitive and specific, so there's no need to send it again because you got the results and you can firmly believe them as well. So you got rid of D.
And then orders stool bacterial cultures is also negative. It's only been a day. Abdominal exam is benign. There's really no reason to send the cultures.
So you're getting rid of stool cultures, okay? So you have 2 left, B and C.
And I don't see a reason to giving antibiotics either. I think we would just give an anti-motility agent.
Okay, so then you choose B?
Yep.
Okay, why?
Why? Because I mean, she's been on antibiotics. It's not C. diff, and we ruled that out. But just antibiotic therapy itself can cause diarrhea.
Right.
And she doesn't have really bad diarrhea. I think she requires supportive care. Very
good. So yeah, the answer is B, antibiotics. So typically when you have a patient that's hospitalized, generally in a controlled environment, and they present 3 to 5 days later with diarrhea, your first thought is obviously C. diff. If C. diff is negative with PCR or toxins, whichever one you test with, then it's very unlikely that it's infectious diarrhea from an infectious source like invasive bacteria. You want to typically, it can be typically caused by the medication the patient's getting, the diet changes, the underlying illness that they might be there for, or the antibiotics that they may get treated with as well. So again, you want to give them some anti-motility agents at that point that might help them as well. So diagnostic evaluations for C. diff infection is appropriate for all patients in hospital-acquired diarrhea, regardless of antibiotic history, right? We already did that. And then PCR is highly sensitive and specific, so we know we can believe that. Antiparasitotic agents should be avoided in C. diff infections because obvious reasons, we already know that, toxic megacolon. And for non-infectious diarrhea, anti-motility agents may relieve the symptoms, and the symptoms could be caused by the medication they've been getting, various different reasons, okay? And then other than C. diff, hospital-acquired bacterial gastroenteritis is exceedingly rare. What about this one? Next person? Yes. Well, yeah. So C. diff is still a common hospital-acquired infection, right, of cause of diarrhea. And so before you give any sort of anti-motility symptomatic treatment, you want to make sure you rule out C. diff because that can worsen the underlying issue and also cause complications, right? Toxic megacolon and sepsis.
Going back to the previous question, while you're awaiting the C. diff results, should you treat that patient?
Well, it doesn't take very, very long. I mean, how long does it take? 2 days over here? A day? Why it's a PCR. It shouldn't take super long unless they send them out now. I think they do send them out. They send them out, right? So no. Again, you want to. I would. Is the potential complications of treating a patient that has C. diff with anti-motility agents is kind of high. So I wouldn't recommend treating the patient with. Oh, you're talking about like empirically treating them? I still don't think that it's indicated to give loperamide or any anti-motility agents if you have a C. diff infection. Period. Oh, you're saying empirically? Sure, yeah. I mean, if you think there's a high suspicion, let's say it's a chronically ill patient on antibiotics, now has diarrhea at the potential of decompensating, right? Then you can choose to treat the patient empirically. However, yeah. However, which algorithm was that? Oh yeah, it's stuck. Hold on one sec. There we go. This one right here. Right here. So let's look at this. If you look at this, you can see this would kind of fall into this area, right? It would not just be watery diarrhea. Let's assume that there was, let's say, patient fall into moderate severe illness, and then there was non-travelers associated diarrhea, possibly low-grade fever. Okay, but again, this is more so based not hospitalized patients. This is not pertaining to a hospitalized patient, but if it's a hospitalized patient, it kind of switches your thought process. Again, you have a suspicion for possible C. diff. If you have a suspicion for C. diff and the patient's severely ill, you can go based off the suspicion. If the patient's severely ill at the risk of decompensating for the diarrhea, then maybe you can treat empirically. But if the patient's not at risk of decompensating for the diarrhea, I would say you can wait for the test results to come back and then start the patient on treatment. Because patients, there's no need. A little bit of diarrhea might be annoying to the patient, but if there's no risk of decompensation, then you would typically wait for that. Okay. All right, so we got this one, and next one.
Okay, so a 29-year-old woman with a one-day history of diarrhea. She notes liquid stools with no mucus or visible blood. She has mild abdominal cramping relieved by defecation. She reports no nausea or vomiting. 3 days ago, she ate almond butter from a manufacturer that posted a voluntary recall of the product due to contamination with Salmonella branderup. On physical examination, temperature is 37.9, blood pressure is 116/52, pulse is 90, respiration is 18. The patient's abdomen is soft and mildly tender with hyperactive bowel sounds. Laboratory studies reveal a leukocyte count of 9,700. Which of the following is the most appropriate treatment? I think the answer is D, no therapy.
Okay, so you say no therapy. So why not the other ones?
Well, so for starters, so the duration of her symptoms, she doesn't have blood in her stool.
Okay.
She does talk about some exposure, but she
Right.
still only had 1 day, and she's talking about this 3 days ago. So I would have thought if she was going to react to this almond butter, probably would have had a response sooner.
So you think that she actually doesn't have the salmonella infection?
I don't think so.
So usually you can assume if they're giving you a question vignette, they're saying that this is the organism she was exposed to, then typically that's the reason she's having the diarrhea. So yes, so she does have a salmonella exposure and infection. Okay, so she's having this mild diarrhea with no mucus or visible blood, right? So, but she's having mild abdominal cramping. She has a fever, right, a low-grade fever, and she's her pulse rate's 90. So she seems mildly ill, not severely ill. And we're assuming that it's salmonella. So you picked no therapy based off the fact that she's mildly ill. But remember we were saying earlier in our chart that, salmonella can have therapy. So do you still want to keep that same answer?
Well, yes, because
Yes.
looking at your algorithm, she's still in the mild illness, regardless
Good.
of the exposure.
So right. So actually, two reasons why there's no therapy over here. So even though our last chart said that, okay, well, remember I said if it's a severe disease, then you can consider it, despite what we do or do not prescribe antibiotics with, and if you have an identifiable organism, we may need to treat. So this patient, she's 29, she's young, generally healthy female. She has known exposure to salmonella, so she actually, we can assume that has the salmonella organism, and even if we sent the culture, it would come back positive. But important facts to remember is one, she has a mild illness, so you can give her a chance to heal or a chance to be self-limited. But also remember that with non-typhoid strains of salmonella, antibiotics can also have been shown to prolong the carrier state and also shed the bacteria more, spreading it in the community. And it hasn't really shown much to decrease the symptoms, the time duration of symptoms as well. So someone who is non-toxic, someone who's young, able to tolerate PO, typically you don't need to give them antibiotics for a salmonella infection. But like I said earlier, if they are elderly or if they are more toxic, then you can consider the therapy at that point. So again, it's all clinical. And finally, I think it's the last question. Yeah, it is. Last question.
So a 67-year-old man is evaluated in the emergency department for sudden onset of severe periumbilical pain followed by an episode of emesis. His medical history is notable for hypertension, type 2 diabetes, chronic AFib. His medications are metformin, metoprolol, glyburide, aspirin, and losartan. On physical exam, temperature is 38.2, 100.8. Blood pressure is 92/44. Pulse rate is 112. Respiration rate is 22. Oxygen saturation is 95. Breathing ambient air. The chest is clear on auscultation bilaterally. Cardiac examination reveals a irregular rhythm. Abdomen is non-distended, mildly tender to palpation, but without guarding or rebound tenderness. During the examination, the patient is found to have a forceful bowel evacuation. Findings of the abdominal radiograph are normal. Which of the following is the most likely diagnosis? So I think.
So what is summarize the vignette? Like, what are a couple of important facts that they showed you when what they told you whenever you were reading it?
67-year-old guy comes in with abdominal pain and emesis. He has a history of AFib. He seems like pretty ill. He's febrile, hypotensive, high respiratory rate. He seems like he meets like a sepsis criteria.
Yeah. So one important thing is that he has pain that is out of proportion to his exam.
So
right?
that's pointing towards A, mesenteric ischemia.
So why not D? What's the difference?
Colonic ischemia. It's just distension, I guess. Wait, no.
Right. So there's a difference, right? The mesenteric ischemia and colonic ischemia are two different parts of the small and large intestine. So with mesenteric ischemia, you typically affect the small bowel, which can call this large volume secretory diarrhea. And colonic ischemia will be typically the watershed areas, which is your splenic flexure, for example, which can often be bloody diarrhea, not as large volume, not as forceful. And so you had chose acute mesenteric ischemia, which is an important consideration and finding as well, of course. Okay. So I described to you the findings already. So next lecture we'll have is going to be on chronic diarrhea, typically more than 4 weeks. So just to kind of tie up the loose ends for diarrhea, and that's pretty much it. If anybody has any questions, please, these are my references. Very good.